Welcome back. If you just joined our program, we're discussing healthcare this evening. My guest is Clayton Samsudin, and you'd like to email, my details will appear on the screen, and we'll deal with those emails on the next program. Let's just go back. So understand your medical aid, understand what you're on, understand the advantage of networks, and then the last question is, are medical aids trying harder to get their doctors to join as networks, and what is the stumbling block?
So the issue with the networks, when you're speaking specifically about GPs and specialists, as an example, we're not talking about hospital groups here. The issue, I think, comes in where the doctors are there. Now we get to a clinical protocol. What are they, let's say, prescribing? And what they prescribe in terms of medication is very different to what is on the medicine formulary of the particular medical scheme. Now what happens is that the member gets to the pharmacy and now there's a co-payment. And this becomes a dissatisfaction between the patient and the doctor because something was prescribed that's not on the medical scheme's formulary and the co-payment then applies. And so the way to deal with this is to just always check whether your doctor is firstly on the network or even the specialist, and most of the healthcare providers have online systems today like find a healthcare provider, and in that way you'll know that that provider not only is equipped in order to prescribe medicines that are on the formulary, but also there won't be any co-payment. To answer your question, there are particular GPs and specialists that have, as an example, signed up to the network. And of course, I mean, we know that healthcare product providers and funders have got actual teams that go out to engage GPs and specialists to increase the network. But you have this of new ones coming on and new ones falling off because of the experiences I've just shared with you.
You know, my wife is not a well lady, and she's got quite a lot of specialists. Every one of those specialists, because people believe that anyone who's a network is an inferior doctor.
Yeah.
My wife's doctors are the best you can get, and they're all networked, I'm pleased to say.
Yeah.
So let's just talk about a confusion, the role of gap cover.
Yeah.
I mean, there's a complete people misunderstand gap cover. You have a small lower medical aid with a gap cover. It doesn't cover all the needs that you have.
No. So what we've got to understand is that medical scheme does not provide full cover, whether we are talking about major medical or day-to-day. That is a fact, and I think we must all get accustomed to that. Gap cover, on the other hand, has become a necessity because of that fact that medical schemes don't provide full cover. So what does gap cover do? It provides the difference in the rates charged in hospital between what specialists charge and what medical scheme pays. Then there are co-pays, deductibles, sublimits, there's emergency, there's casualty, there is premium waiver as an example, there's oncology co-pays, but that depends on your plan. So just like the medical scheme, gap cover's got options too. And the lower option you purchase, the lower cover you have, whether it's the lower rate of reimbursement or certain things are just not covered. So you could have gap cover and believe you've got a cancer copay benefit, but you don't, because that option doesn't provide for that. So you have to look at the two together. It is, unfortunately, the missing piece, I think consumers realize when it's too late. When you've had a triple bypass and you got 127,000 copay, and if you had gap cover, that would have been covered. Then it's a bit too late. It's a financial disaster.
Clayton, in financial planning, the starting point is to look at someone's budget.
Yeah.
And it's quite amazing. But there isn't an individual who I've seen this whole year where there's not a budget on what your medical aid costs, and then additional medical expenses, which are the co-payments.
Yeah.
Quite amazing how that all adds up. And then when you talk about treatment protocols and formularies, how does that affect the costs going forward?
So I first would say it's part of the decision-making process. So let's just look at a medicine formulary, something we spoke about earlier. And this is the main reason for the out-of-pocket expense. So let's use a quick example. Someone suffers from cholesterol, they go to their GP, there's medication prescribed, but no one looks at what is actually covered by the medical scheme and that option. So that's a formulary. Formulary says, you've got cholesterol, this is the list of medications we provide, but it doesn't just stop there. It's medications that's provided per option. So if you're on a more comprehensive option, it covers more expensive medications. So it's not just what you read in benefit and cost. There's this thing called the fine print, and that is very, very, crucial. It's essential to look at. So you could say, well, I'm on this option and I'm going to pay 200 and odd rand out of pocket when I collect my medication, but maybe if you just looked at another option, you'd have no co-payments whatsoever. And maybe if you went to the doctor and said, look, this is the medication that my medical scheme will pay for in full, your doctor specialist may just very well prescribe what is there if it's possible. Of course, if you've got multiple conditions, that may not apply.
Yeah, and then Clayton, so many other questions which we'll deal with in the new year again. But the one question is asked all: how do you know if your medical aid's healthy and likely to survive? Because what's happening is medical aids are aging. Younger people are downgrading their medical aids, taking gap cover and various other things. The cheap cover and the cost for hospitalisation still hasn't come in. So the real issue is the smaller schemes are not growing.
Yeah, I would say the first go-to point is the solvency. The solvency ratio is by far the best indicator as to whether your medical scheme is performing well.
How does no one knows that? No one ever knows that number.
Well, from a quotation process, on our systems, we could just, by click of a button, we'll know what the solvency ratio is of a scheme. Again, we get to the intelligence component. The other issue is to look at the average age. You were just mentioning aging membership. The older the membership, the higher the cost of the benefit is. That's quite simple. But let's talk about something that maybe it's a better indicator for just a layman. And that better indicator is what has been my increases over time. If it's been stable, if it's been something I can bank on, like it's between this window of certainty that one would call, then we know, okay, the scheme is performing well. But if we suddenly see a 14% increase and then next year,
well, look at Jen's government employee up 9.8%.
Well,
Discovery only from April 7.2 as an average.
Correct. So that's what I'm talking about. We would have schemes that would have an 11% increase in 1 year and 7% the next year. That's just unstable. That doesn't do anyone favors. We should rather than stick in that what I just called, and I've borrowed this term from Discovery Health, it's that window of certainty. What can we be sure of? Is the ballpark increase going to be year on year on year? And that is the best indicator.
Clayton, let's just talk about 2026.
Yeah.
Anything you want to point out in terms of major changes?
No, not really. I just think members, we're getting, we always say, we've been saying it for the last 5 odd years, NHI is far, NHI is far, and some days it's going to happen where it's not so far. We have to get accustomed to, wait a minute, there are networks, there are formularies, there's treatment protocols, and we've got to understand that. There's more and more tighter restrictions that's going to come in, more limitations in an attempt to contain the cost. And so we have to get accustomed to that. So I would say we're going to see more of that tightening that's happening, less freedom of choice. And then lastly, we're going to start seeing this hybrid, which we've started to see happening this year, where there is an insured benefit structure for, let's say, a basic package of day-to-day benefits coupled with a medical savings account. So they're almost saying, well, your medical savings will be depleted, but you could have an unlimited GP visit. And if you then need medication, you could pay that out of pocket. So I think that's where the future is going. We're moving, like the traditional schemes were, where you knew exactly what your benefits were. Then we had the medical savings account, and now we're in this hybrid situation. And that's the cycling that's happening. And so I think next we're going to see these hybrid models come in.
And I must say to viewers, remember, if you're an individual and you're on a medical aid, someone is earning a commission. And you may not know who that person is. You may have had someone who introduced you 15 years ago. That commission that they're earning, they need to work for. You need to contact them, find out, have a meeting with them, let them take you through exactly all the options, because if you do, you can at least understand, and knowledge empowers. At the moment, so many people just carry on paying. If you look at your budget, and you look at life insurance, and you look at pension fund, most people are contributing more to medical aid than what they are to life insurance and to and their pension fund, and that cost is going to go up. I'd like to take one or two emails before we go. Stephen in Saxwell says, please explain how digital is driving innovation in healthcare services. You have touched on it, but just anything else you'd like to add to that, further than what we spoke about in the first segment?
Well, I think two things that's important is it's reducing the administrative cost of the medical scheme, and that again translates to a cost saving for the employees. It's becoming a lot easier to do things from your smartphone. I mean, you could scan a claim and it will be paid quicker than if you had sent it to us, you know. And I think brokers also need to evolve through that. You know, they need to understand, wait a minute, we've got a bigger job to do than just the servicing component.
Clayton, the last question for the year, and before I do my closing, when do children have to come off my medical aid and go onto their own medical aid? This is from David in Centurion.
Again, it depends on your medical scheme and it depends on what they're doing. So if they're older than 21 and if they are studying, they can be on most medical scheme and pay minor dependence rates. On Discovery, as an example, no, they'll pay an adult dependent rate irrespective. And they should go on a plan of their own simply because invariably they wouldn't be as, or rather require the level of cover that their parents do. So they can step down a lower plan and that would save the entire family some cost.
Well, the Government Employee Medical Aid Scheme has just announced a 9.8% increase in contributions for 2026. Discovery's weighted average increase is at the lower end at 7.2, and as I mentioned before, I remain deeply concerned that members of medical schemes are not fully appreciating the implications of these annual increases. At the current rate, your medical aid contributions will double in 7 to 10 years and then double again in a further 7 to 10 years, which is 14 to 20 years. If you do not take your healthcare seriously and fail to plan properly for future healthcare costs, many South Africans will end up finding themselves unable to afford medical aid at the very stage of life when they need it most. This does not even consider the rising costs of co-payments or the additional expenses when consulting medical practitioners who are not part of your scheme's designated network. Clayton, thank you for joining me tonight.
Pleasure.
Thank you for joining me on all the programs you've had during the year. I wish you and your family, and I wish all our viewers and all the people in the studio who've been supportive of our programs this year. It's important to note that our program to provide information and should not be construed as advice. Next week's program, although it will be pre-recorded, will be dealing with short-term insurance. I'd like to thank you for watching, and particularly to my team behind and at the cameras, thank you for everything you've done for me this year. All the best. Good night.